main site for the production of aldosterone. The sites are named based on the target of their products. Okay? So it's glomerulosa because the target of its product is the glomeruli, right? And then you have the zona fasciculata, which is the main source for the production of cortisol. And then you have the zona reticularis, which is where your androgens, primarily DHEA and androstenedione, is from. Now, remember, I said androgens, right? Because testosterone is an androgen, but it's not produced in the adrenals. Right? The main androgen from the adrenals are the androstenedione and DHEA. The medulla is the main site for the production of catecholamines. So the catecholamines in the medulla, they are 80% epinephrine and 20% norepinephrine. Okay? So you remember that for the sympathetic nervous system, they use norepinephrine as a neurotransmitter. And as a matter of fact, it is believed that the adrenal medulla is actually a modified sympathetic ganglia. And the reason that is believed is because the adrenal medulla is innervated directly by preganglionic fibers of the sympathetic nervous system. Because under normal circumstances, the preganglionic fibers, they end at the ganglion, right? And then the postganglionic fibers take up from the ganglion to the organ, right? Since the preganglionic fibers of the sympathetic nervous system innervate the adrenal medulla directly, the adrenal medulla is considered a modified ganglia, okay, of the autonomic part of the sympathetic pathway. That is important. Now, the adrenals makes corticosteroids, right? And again, these are corticosteroids because they are steroids from the cortex of the adrenal, right? That is what they are. And they are named based on their function. So you have the glucocorticoids that are responsible for maintaining blood sugar, right? The primary one is cortisol. So cortisol, and then you have the mineralocorticoid. The primary one is aldosterone, okay? So cortisol is responsible for three main functions: keeping the blood glucose level normal. That is why it is a insulin counter-regulatory hormone. You remember that, right? And then also modulating the immune system, right? So, and then enhancing vascular tone, okay? So, when it comes to keeping blood sugar normal, exactly what does the cortisol do? It promotes new glucose formation in the liver, that is gluconeogenesis. It promotes peripheral breakdown of protein into amino acids for glucose formation in the liver. So not only does it stimulate new glucose formation, it mobilizes the resources for that new glucose formation from the periphery into the liver. And then it inhibits glucose uptake by fat and muscle cells. Its goal is to keep blood sugar normal. Okay, so it promotes synthesis and reduces uptake. Okay? And then it promotes fatty acid release from adipose tissue for energy production in the muscle. Right? And then in terms of how does it immune modulate, it upregulates all of the anti-inflammatory hormones, and that is why we use steroids in inflammation. Okay? Because it upregulates anti-inflammatory hormones and downregulates pro-inflammatory hormones. The catecholamines, they cause vasoconstriction, but they are much more effective in the presence of cortisol. So in the absence of cortisol, the catecholamines are not as effective as they could be. Okay, that is what I mean by it enhances vascular tone, right? Then the mineralocorticoids, primarily aldosterone, it regulates mineral salt reabsorption in response to changes in blood volume and blood pressure. Remember that. Aldosterone works to maintain mineral salt reabsorption, primarily sodium, and that reabsorption is in response not just to blood pressure, but to blood volume also. That difference will be very clear to you later on. But it's important that I don't want it to lump them together. Blood volume and blood pressure, in response to aldosterone, there are some interesting differences between them. Now, so how does aldosterone work? Aldosterone stimulates the reabsorption of sodium in exchange for potassium and hydrogen ions in the cortical collecting duct of the nephron. So the cortical collecting duct of the nephron is the primary site of action of aldosterone. Okay? You remember that the glomerulus has the proximal convoluted tubule, the loop of Henle, right? The distal convoluted tubule, then the collecting duct, right? Now, the portion of the collecting duct in the cortex is what is called the cortical collecting duct. Okay, that is the site of action of aldosterone. And remember, you can't. This is one thing you can't forget. Aldosterone stimulates the reabsorption of sodium at the expense of potassium and hydrogen ion. So if you have a lot of sodium to be reabsorbed, aldosterone will keep reabsorbing them at the expense of potassium. When the body becomes low in potassium, it starts excreting hydrogen ion to save sodium. This is the reason that metabolic alkalosis and hypokalemia are common in people that have excess aldosterone. Okay? And not just in the kidneys. As a matter of fact, distal colon and the sweat glands also retain sodium in response to aldosterone stimulation. Even though the primary site for sodium reclamation is in the kidneys, it is not the only one. The sweat glands and the colon respond to aldosterone. Okay? And aldosterone works very closely as part of the renin-angiotensin system. So you have the angiotensin 2 from the renin-angiotensin system and the extracellular potassium. They also modulate the synthesis and secretion of aldosterone. Okay? And it is very important for you to realize that the production, the synthesis and secretion of aldosterone from the adrenals is much more regulated by the renin-angiotensin system than the hypothalamus-pituitary adrenal axis. So you have ACTH from the pituitary, right? Corticotropin releasing hormone from the hypothalamus, modulating the function of the adrenals. Yeah, that is very true for the portion, for the zonal fasciculata that produces cortisol. But for the zona glomerulosa, where aldosterone is produced, that particular zone is more responsive to the renin-angiotensin system than to the pituitary and the hypothalamus. Are you with me?
Yes.
Okay. So, that's what I'm saying here, that much more so than the HPA axis. And then you have the androgens, and like I said, androstenediones and DHEA, they have no direct effect on the body, but they serve as intermediate for the synthesis of testosterone and dihydrotestosterone and estradiol in the peripheral tissues. So there is no target for these androgens, but they provide a reservoir where the other tissues of the body can make the active androgens. Okay? Now, I put this here not for you to memorize it. I'm sure you've seen this diagram before, right?
Yes.
Okay. The reason I put this here is for you to understand that all steroid hormones, all of them, they all start with cholesterol. Okay? Okay? And there are some important transition enzymes that allow the different zones to get the precursor they need to produce their own substance. For instance, let me give you an example. Look at 21 hydroxylase. If you don't have 21 hydroxylase, you're not going to be able to form aldosterone. You see that? 21 hydroxylase is key. If you don't have it, progesterone will accumulate. And because you don't have 21 hydroxylase to convert progesterone to 11-deoxycorticosterone, progesterone is going to accumulate, pregnenolone is going to accumulate, and you're going to end up forming excess of the glucocorticoids, right? That is very important for you to understand. Now, you also realize that this 21 hydroxylase is also needed for the production of cortisol, right? So if you don't have it, not only will you not be able to make mineralocorticoids, you're not going to be able to make glucocorticoids as well, right? And then see what happens. You begin to shift products this way, because if you don't have 21 hydroxylase, you can't form glucocorticoids and you can't form mineralocorticoids. You're going to be forming excess progesterone and pregnenolone that are all going to be converted to 17-hydroxyprogesterone, right? And 17-hydroxypregnenolone. And because they can't go down, they move over to the other side. And what do you have now? Now you begin to form excess androgens. Now you understand why you have virilization. Because of this excess androgen production when you have 21 hydroxylase deficiency. That is the point of this slide, to help you understand the biochemical basis for some of the excess hormones that you form when you have deficiencies of specific enzymes. Okay? And again, like I was saying, glucocorticoid synthesis is regulated by the HPA axis, and this is the HPA axis, right? So you have the corticotropin releasing hormone from the hypothalamus to the anterior pituitary, and then in response to CRH, the anterior pituitary produces the adrenocorticotropic hormone, and then that goes to the adrenals, and you see more emphasis on glucocorticoids. And then the glucocorticoids exhibit negative feedback on the hypothalamus and the pituitary. Right? Okay. Now, there are some important things for you to understand about the way ACTH works. ACTH from the anterior pituitary stimulates cortisol synthesis in the adrenals, like I said. Now, the secretion of cortisol is not even throughout the day. Cortisol secretion is highest in the early hours of the morning and lowest in the evening. That fluctuation in the secretion and synthesis of cortisol with periods of day is what we call circadian rhythm. It's not unique to cortisol production. It is common to so many hormones and so many biological processes in the body. Okay, it's like the body, you know, when you leave your computer for a while and it goes down, the screen shuts off, and you think the computer is off, but it's actually still on. But once you touch it, it revs back up, right? The body exhibits exactly the same thing. Okay, so the production of cortisol is not just it's not even throughout the day, and that is the reason I told you earlier. Most strokes and heart attacks, they happen in the early hours of the morning. Okay, I'm sure those here people know that, right? Okay. And then, like I said, cortisol suppresses that. Now, see what happens when cortisol is formed. Cortisol is active, right? And it does all those things it needs to do to keep blood glucose level. Active cortisol is converted to inactive cortisol by this very important enzyme, 11-beta hydroxysteroid dehydrogenase. This enzyme 11-HDS is actually HSD is actually at the receptor site. So once cortisol stimulates the receptors and is done, it is converted to cortisone by 11-beta hydroxysteroid dehydrogenase. You all know about licorice?
Mm-hmm.
Okay. The licorice can raise your blood pressure because licorice actually inhibits that enzyme 11-beta hydroxysteroid. That is why people that eat a lot of licorice can get high blood pressure. Okay? It's because licorice actually inhibits 11-beta hydroxysteroid dehydrogenase, and it allows cortisol to linger longer at the receptor site. So it overstimulates the cortisol receptors because licorice is inhibiting it. Okay? So that's why licorice can actually give you hypertension. And that's a very important question. And I've not seen a lot of people taking licorice in California, but I think in the southeast somewhere, people just like a regular snack or candy that people eat, but be aware of it. Okay? So now that we've learned about the background for the adrenals, let's talk about adrenal deficiency. So when we're talking about hypoadrenalism, we're talking specifically about deficiency of adrenal corticosteroids. And specifically, most of the time, we're talking mostly about cortisol. Okay? It is also known as adrenal insufficiency, or more specifically, hypocortisolism. Okay? These are other names for it. Again, this is your regular axis. So when you have adrenal insufficiency, there are actually three types of it. There is the primary, that is from the adrenal, and there is the secondary, that is from the pituitary, and there is this tertiary that is actually from the hypothalamus. We'll talk about that in a little bit more detail later on. Now, let's start with the adrenal, the primary one. The primary one could be congenital. That is your congenital adrenal hypoplasia or congenital adrenal hyperplasia, both of them. So let me give you, you wonder how can both hypoplasia and hyperplasia give you hypoadrenalism? In congenital adrenal hypoplasia, the gland is underformed, is underdeveloped. Okay? So that is why it is congenital adrenal hypoplasia. Now, in congenital adrenal hyperplasia, there is a fully formed adrenal, but it has some enzymatic deficiencies. And because of the enzymatic deficiencies, cortisol is never really formed. So the negative feedback loop never kicked in. So the adrenal that was normal gets overstimulated by ACTH and becomes big, trying to respond to cortisol deficiency, but it can't because it's an enzymatic process that is, an enzyme is missing. So the factory gets bigger, but the enzyme that is needed to cut it off is not there. So that is why you get this congenital adrenal hyperplasia. You understand it now? Good. And then there is the familial glucocorticoid deficiency, and there is all-growth syndrome that has this AAA. We'll talk about that down later on. AAA, but all of this, I've never seen any of this, okay? So this is one of those things I'm just telling you. You just need to know it. It does adrenal, primary adrenal insufficiency can be primary, and the primary can be congenital or acquired, and it could be hypoplasia, all growth, yada yada yada. Just FYI, okay? I don't even think anybody will test you on this one because you're not likely to see it. Okay. Now, the ones you must know is the acquired one, Addison's disease. I've seen it, even though if they're going to ask you any question on endocrine, apart from diabetes, it will be this one, Addison's disease, okay? It's very common. We'll talk more a little bit about it. So that is all about primary adrenal insufficiency. Now, what about secondary? That is usually from pituitary. The secondary adrenal insufficiency could be part of panhypopituitarism, which we talked about already, right? Or it could be isolated ACTH deficiency. I've seen panhypopituitarism, I've not seen isolated ACTH deficiency. Okay, so that one does not require anything. You just need to know it's part of the manifestation of hypopituitarism. Okay. Now, the tertiary adrenal insufficiency is the one you as a provider are likely to cause. Because what happens is when you put patients on steroids, that is why we don't like putting people on steroids for a long time. When you put patients on steroids for whatever reason, inflammation, asthma, whatever it is, you give them the steroid you give them gets ultimately converted to some cortisol of some sort and suppresses the hypothalamus, right? And guess what? When you overstimulate and you have a lot of cortisol in circulation, what will the hypothalamus do? It will downregulate its receptors, shut it down. And remember, those receptors are proteins, right? Once they're downregulated, your patient will be fine for as long as you keep supplying the steroid. If your patient now stops taking the steroid, or you stop taking the steroid, it takes time for the body to sense that your patient has stopped. It takes time for the body to send information to the hypothalamus that you no longer have exogenous supply of corticosteroids. You need to start making corticosteroids. It takes time for the adrenals to now step up those receptors, right? Send the corticotropin to the pituitary. Have the pituitary release ACTH, have ACTH to go to the adrenals, and now start back up the factory. During all of that process, your patient will not have the cortisol they need. That is the pathophysiology of tertiary adrenal insufficiency. It's from sudden withdrawal of chronic high-dose steroid therapy. It could also follow, like I told you earlier on, if you take a pituitary adenoma out, you know, a pituitary adenoma that was producing ACTH, right? And it's not subject to hypothalamus, keeps cranking out ACTH, overdriving the adrenals, right? When you now take it out, the system crashes before the hypothalamus can recover from that prolonged suppression, right? And before the normal adrenal tissues can recover from that constant outpouring from that prior adenoma that was taken out through surgery. Did you understand that? Yeah. I use too many words, and when I do that, people get confused. So if somebody had Cushing's syndrome, Cushing's disease, right, as a result of pituitary adenoma that was producing ACTH, right, they get excess cortisol because there is this autonomous tumor in the pituitary that is producing ACTH that is not subject to negative feedback. When you now take that tumor out, the hypothalamus needs time to recover, right? Just like it did need time with the steroid therapy, it needs time the same way. So that is why the two causes of tertiary hypocortisolism are sudden withdrawal of chronic high-dose steroid therapy and that surgery for Cushing's disease. Okay? So let's talk a little bit more now in details about primary adrenal insufficiency. You notice that I switched it now. I'm going to talk about Addison's first because that is the one you're likely to see. And I left the congenital one in the back, right? Even though under normal circumstances, when you're doing a lecture on causes of things, you like to talk about congenital and acquired, right? But in this case, I'm flipping because this is what I like. So let's talk about Addison's disease. In the United States, 80% of your Addisons are autoimmune diseases, okay? They are as a result of antibodies against 21 hydroxylase. You remember where that 21 hydroxylase is? It's is a very critical enzyme for cortisol production and for mineral corticoid production. So once you miss that, you have antibodies against it, you have another problem. Okay? And that autoimmune process is usually, mark my word, is usually isolated. But it can be part of what is known as polyglandular autoimmune syndromes. In other words, the antibodies can attack just the adrenals and the 21 hydroxylates in the adrenals and leave it there. Or occasionally, they can attack other endocrine organs like the parathyroid and give you these polyglandular autoimmune syndromes. We'll talk about that later on, the two of them. Okay? And then the next cause of Addison's deficiency is this thing called Waterhouse-Friderichsen syndrome. But basically what it is bilateral adrenal hemorrhage. So when you have bleeding into the adrenals, it was first discovered in patients with septicemia and DIC. You remember what DIC is, right? Disseminated intravascular coagulopathy. Right. When you have DIC, especially when that DIC is caused by meningococci. So when you have a fulminant, that's a very serious, deadly meningococcal infection in the blood, you can get bleeding into the adrenals as part of the manifestation of DIC. Bleeding into the adrenals as part of the manifestation of DIC in patients with meningococcemia is what is known as Waterhouse-Friderichsen syndrome. Okay? But that is not the only cause of bleeding into the adrenals. You can bleed into the adrenals as part of heparin-induced thrombocytopenia, which looks so much like DIC, but only this time it is induced by heparin, right? You can get bleeding into the adrenals as part of your antiphospholipid syndrome. You remember that from hematology, right? Excellent. Now, you also have infections. This is where we are different. We're in the first world, right? There are other worlds, other places on this planet, right? And those developing countries there are more people there than there are in the developed countries. So if you're talking worldwide, the commonest cause of Addison's disease worldwide is tuberculosis of the adrenals. Okay? So if you're dealing with a recent immigrant with Addison's disease, you're more likely to be dealing with TB than you are to be dealing with autoimmune disease. Okay? Occasionally, adrenal infection as a cause of Addison's disease can be due to histoplasmosis in the Midwest states like Ohio, or it could be due to cocci in the Southwest states like California. Right? But it is rare. And then you have non-infectious causes like sarcoidosis. So when should you think about sarcoidosis as a cause of Addison's disease in the patient? Your patient will have the history of manifestation of sarcoid. Right? So if somebody presents like they have Addison's disease, and then they have lupus perennial, and they have all this sarcoid, chest x-ray having hilar lymphadenopathy, you know that is not part of Addison's disease. That should be your clue. This could indeed be sarcoid causing this Addison's disease. Remember that. Okay, so that is the way I will pitch that in an exam. Okay? And of course, the last set of causes for Addison's disease are infiltrative disorders, hemochromatosis, amyloid, malignancies, and this X-linked disorder called adrenal leukodystrophies. Fatty acid buildup in the renal vessels, testes, and nerve tissues. I've not seen that, but I've known about it all my life. Okay? just remember infections, especially TB worldwide. Remember, if somebody has history of hemochromatosis or they have clinical manifestations of hemochromatosis, what are those? Bronze diabetes, right? Hyperpigmentation, diabetes, arthropathy at a relatively young age, right? And then you see evidence of Addison's disease in them. You're probably dealing with Addison's disease as a result of hemochromatosis. Okay, so the point of listing causes of these things in all lectures is for you to know how to evaluate patients when you see them, right? They may have, the easiest way they could come to you is somebody with an established diagnosis of amyloidosis. But the patient may not have had the diagnosis of amyloidosis because nobody has taken time to think through what the patient is presenting with. The patient could be presenting with, for instance, restrictive cardiomyopathy. You do a routine EKG and you see low voltage, right? And then you see low voltage on the EKG, but then you do echo, you see cardiomegaly. You know right there and then that there is something infiltrating the myocardium, right? That should be your clue. Or you tell your patient, open your mouth, say ah, and the tongue fills the entire oral cavity. You know, wow, this is looking like amyloidosis. And then you now do your labs and you examine your patient and see, oh, he has low potassium, high potassium, low sodium. It's like a little darker than normal. Then you know that you're dealing with amyloidosis. So it is important for you to pay attention to, I will put a highlight around amyloid, hemochromatosis, TB, and autoimmune. So you just know that these are things that could be picked at you in exams. All right, and then the other set of causes is just FYI are the congenital adrenal hyperplasias, right? So it's a congenital absence of the adrenal cortex. These are pediatric syndromes, and like I said, you see this person here is under the hypoplasia is under development. So they don't just have Addison's disease, they also have delayed puberty because the entire adrenal is under development, right? And they have the congenital adrenal hyperplasia, congenital absence of key enzymes, like I said earlier. They present with precocious puberty. You know why, right? Because in the hypoplastic case, the factory is small, right? So not only are they not able to put out glucocorticoids, they are not able to put out mineralocorticoids, and they're not able to put out androgens. So they tend to have delayed puberty. Whereas in congenital adrenal hyperplasia, because it's a specific enzyme deficiency, the precursors that accumulate, they get diverted into pathways that have the intact enzymes. So they tend to present with precocious puberty. Okay, so you see a 6-year-old boy with beard and muscle definition like he's lifting weight because the androgens are being overproduced because the cortisol and the mineralocorticoids cannot be. Okay, and then you have this autosomal recessive ACTH receptor inactivating mutation that is known as familial glucocorticoid deficiency. So if the pituitary cannot respond to ACTH, or the adrenal cannot respond to ACTH, it can't work, right? So familial glucocorticoid deficiency is an inactivating mutation of the ACTH receptors in the adrenals. And then you have all growth syndrome, again, is an inactivating mutation of this gene. This is way too much information, it's just FYI, okay? But I just needed to know that there is this protein called alanine, right? But AAA, all growth syndrome, is when you have adrenal insufficiency associated with achalasia and alacrima. Alacrima is the deficiency of tear. Okay, so these are people, this is a very important one because you see, the child is really sick, but many times the parents will not know. Because here is a child that will not eat, right? Will not eat because he or she is having trouble swallowing. the parents will not know unless they pay attention, because the children can't express themselves most of the time. So they say, oh, it's a picky eater. And then when the child cries, when he gets hungry, because it's not shedding tears, the parents don't believe that it's really tears. The child is really crying. And the child is sick. You understand why all growth is important? Not because you see a lot of it, but just because of the suffering the children will go through if they have it. Because they have achalasia, they have an acrema, and they have an adrenal insufficiency that nobody pays attention to, because parents feel that the child is spoiled and is a troublemaker. He cries needlessly. That pretends cat cry, that he cry doesn't shed any tears. You know, people believe that if you're not shedding tears, you're just pretending to be crying. Right? Exactly. But this is not the case with all growth syndrome. Again, I put here for you to understand congenital adrenal hyperplasia. I put the same figure that you've seen and you know about already. Then I put some bullet points in it so that you understand this is what I need you to know about this figure. 17 alpha hydroxylate deficiency is rare and is associated with delayed onset of puberty. And I put it here specifically so that you know that when you cannot form 17-hydroxypregnenolone and 17-hydroxyprogesterone, you cannot form DHEA. And if you cannot form DHEA, you can't form androgens. That is why it presents with delayed onset of puberty. Okay? 11-beta-hydroxylate deficiency makes up only 5% of the cases and is not associated with any abnormalities of puberty, because that is the only one where you will find Addison's disease and you don't have any abnormality with sexual development, because it's only in this, is the second to the last stage of forming cortisol, right? The one that everybody talks about, you're likely to see, you're going to see it, is this 21-hydroxylate deficiency. That is what makes up 95% of the cases of all congenital adrenal hyperplasia, 21-hydroxylate deficiency. And that presents with precocious puberty in a female or in a male, extreme virilization. You should understand that. Precocious puberty in females, extreme virilization in males. So this is where you see a 7-year-old boy with beard, mustache, and everything, right? And we'll talk about that, I think, in a couple of lectures down the road. Okay, pay attention to that. Precocious puberty can be isosexual or heterosexual. So a girl can start growing beard at 6. That is the precocious puberty of the heterosexual kind, because the child is exhibiting puberty as if it's a male. Precocious puberty is when a 7-year-old kid, for instance, starts showing growing beard. That is precocious puberty, because here I say precocious puberty, but it's of the same sex kind. We call that isosexual precocious puberty. We'll talk about that in other lectures, right? But all of them together will present with hypoglycemia because cortisol is missing. They will present with hyponatremia because aldosterone is missing. And they will present with hypokalemia because potassium cannot be excreted. Okay? All of them present like that. So whenever you see hypoglycemia, hyponatremia, and hyperkalemia, you must think about adrenal insufficiency. Okay? Whether it's primary, secondary, or tertiary, it's a totally different analysis. But whenever you see hypoglycemia, hyponatremia, and hypokalemia, you must think about adrenal insufficiency. So how does it really present? Very non-specific symptoms earlier on. Abdominal pain, vomiting. Does that tell you anything about adrenals? No. They're so non-specific. Weight loss, muscle weakness. That is why Addison Addison's disease is one of those diseases you must have a very high index of suspicion. You must have a very high index of suspicion. You must know what can cause it. So when you're talking to patients and you're listening to or you're reviewing their system, or you're listening to their story, you must look and recognize any symptom or sign that the patient may report that will clue you in to adrenal insufficiency. Because many, many times the symptoms of adrenal insufficiency are not specific. The only thing that can clue you in sometimes is that they tell you they're losing sexual hairs. They're losing pubic hair, colored hair, but who cares about those these days? Everything is shaved off anyway now. So patients don't even know when they're losing it. So that again, that used to be a little bit more specific, but now you've lost it because of the times you're going to be practicing in, right? So, adrenal insufficiency, what are some of the signs that can help you? Darkening of the skin and orthostatic hypotension. You can't forget that. Anytime you see those two together, you ask your patient, do you think you're getting darker than you used to be? Like, I'm dark-skinned guy, right? But my palm is not dark. The day my palm begins to go dark, then I'm becoming darker than I should be, right? So you can still elicit increased darkening even in dark-skinned people, you know? And of course, for a light-skinned person, they will tell you, I'm getting darker for some reason, right? So, darkening of the skin and orthostatic hypotension are the only two specific signs that, except somebody has been having vomiting and diarrhea, or they have autonomic neuropathy. If you see orthostatic hypotension, among the differential diagnoses on the fingers of one hand, Addison's must be there. Because very few things cause orthostatic hypotension. Voluminous diarrhea, vomiting, or diabetes insipidus, autonomic neuropathy in somebody that has either diabetes, peripheral neuropathy, or other autonomic neuropathies, and then Addison's disease. By the time you're looking at differential diagnosis of orthostatic hypotension, Addison's disease must be very high on the list. And then if you do complete blood count, what else would you see? Neutropenia, eosinophilia, and lymphocytosis. Lymphocytosis is a little bit more specific because very few things will give you lymphocytosis. Okay? Most of the time, lymphocytosis is a result of chronic granulomatous infection. Did you talk about that in hematology? Right. Lymphocytosis, you have the differential of leukocytosis, right? It could be neutrophilia, or it could be eosinophilia, or basophilia, or lymphocytosis. Lymphocytosis is usually due to chronic granulomatous infections like tuberculosis, leprosy, all those rare diseases, right? But in Addison's disease, you see it. Where is your money? In Addison's disease, hypoglycemia, hyperkalemia. Hypoglycemia, hyperkalemia. Hyponatremia, yes, but so many other things can cause it too, right? Hypoglycemia and hyperkalemia, very important, okay? And of course, you have hypercalcemia and metabolic acidosis, right? Why can anybody tell me why you get metabolic acidosis in Addison's disease? Christian.
So you have hyperkalemia.
Okay, you have hyperkalemia, and because you have hyperkalemia, potassium is going to shift inside the cells, right? And adrenaline is going to be kicked out.
Yeah.
Exactly. In addition, you don't have aldo, right? Because you don't have aldo, you're not really reclaiming sodium. And because you're not reclaiming sodium, you're not able to get rid of potassium. So it's multiple processes. So hyperkalemia is, that's how you get hyperkalemia and metabolic acidosis. Okay? Now, remember we talked about hyperpigmentation, but I want you to be very clear. We talked about this when I was talking about the pituitary hyperpigmentation is specific for Addison's disease and is secondary to increased formation of melanocyte-stimulating hormone along with ACTH from the precursor molecule pro-opioid. Remember pump? Remember that? Okay. Pro-opioid melanocortin. That is the hormone that is actually released from the pituitary. It's a giant complex of melanocyte-stimulating hormone and ACTH that is ultimately split into ACTH and MSH. When you have adrenal insufficiency and the pituitary is responding to it by turning out ACTH, invariably MSH gets secreted at the same time. That is what is responsible for the darkening in patients with Addison's disease. Okay? Remember that. And remember what I told you earlier about the tertiary hypocortisolism, when you suddenly withdraw corticosteroids, that actually presents like an emergency. Okay? So, whenever you have emergent or sudden onset Addison's adrenal insufficiency, we call that Addisonian crisis. It's a sudden onset adrenal insufficiency. Look at the causes of it: adrenal failure from hemorrhage or stress, especially in somebody with pre-existing Addison's disease, or you withdraw steroids. A third cause there should be sudden withdrawal of steroids. Okay? And you get into this serious emergency. The patient is not orthostatic in Addisonian crisis, they are hypotensive. Okay? Can anybody tell me why you get hypotension in Addison's disease, Wendy? You lose catecholamine efficacy. Remember that. Cortisol enhances the vascular response to catecholamines. So when you don't have cortisol, the blood vessels are not as responsive as they could to catecholamine. So that's why you get the hypertension. Okay. Extremely important. And that happens on an emergent basis in Addisonian crisis. So under normal circumstances, Addison's patient will present with orthostatic hypertension. But in Addisonian crisis, they present with frank hypertension. Okay. I told you about the story of that woman that was in the CCU for a long time with hypertension. And we're trying to figure out what was wrong with her. And after 6 weeks, the daughter came, the endocrine fellow came. Did I tell you about that story?
Yeah.
Yeah. The endocrine fellow came and told the daughter, go home and bring all the medicine your mother is taking. And brought the medicine, and among the stack of the medicine was prednisone. Apparently, the woman had some kind of problem, and she'd been getting the steroids from Mexico because nobody would prescribe it for as long as she needed it in the US. So she's been going to Mexico to get it. And because she's been sick, she ran out of the prednisone, and she went into Addisonian crisis. Her blood pressure was 80/60. She was in the CCU for 6 weeks. She was not bleeding. We did all kind of tests. Nobody knew what the heck was going on with her, but we couldn't release her to the floor because of the systolic of 80. She was dizzy every time she stood up. It cost the university, CCU is $5,000 every day. We did not figure out what to do for 6 weeks until this endocrine fellow came and did what we should have done as a team, right? And I was the resident on the service. But none of us thought about it. CCU is not where you think about endocrine disorders, right? You talk about MIs, and you're watching for pericardial effusion and listening to heart for new moments. You're consumed with that. Nobody was stepping back to rethink this case. And guess what? Just a single shot of prednisone. She was out of the CCU the next day. She was home the following day. After 6 weeks. 5,000 times 6 weeks. So sometimes when you're not as good a clinician as you could be, you cost the system money. And that's why it's so important that I make you the best you can be. Because not only do you not have that kind of luxury, especially now, 50% of GDP on health, that is not sustainable. You see all the Democratic debate, everybody's talking about Medicare health coverage. People are dying needlessly. We need to address this. And part of what we need, in addition to good policies and presidents, seasoned providers that will remember and know when. If you cannot make a diagnosis, that is when you step back. You have to learn to step back as a provider. Believe you me, 75% of the time you will be confused by your patients. You will not be able to reach a diagnosis from talking to them. By the time you examine most people, you will reach a diagnosis 90% of the time. About 95% of the time, you will need some basic lab tests. There is that 1 to 5% time that you will do all the routine tests and you're not going to come to it. It's not going to lead you anywhere. That is when you go back and you look at that standard patient database. You read it from the beginning to the end. You talk to the patient, say, tell me again, how did this happen? If you do that, most of the time, you will get to a diagnosis. Of course, there is that 1% that you will never make a diagnosis. You follow the patients right to their grave. You could never tell anybody what you're treating. You just say, well, we presented with diarrhea, what is causing diarrhea? We don't know, it's just diarrhea. We're following and replacing whatever the patient is losing until they die. And then autopsy will come and tell you some weird fungal infection somewhere. There's no way I could have known that. You want to be able to walk away from a dead patient knowing that you were on your best. You did everything. That what they died of could not have been diagnosed. If people die of things you could have prevented, believe you me, there is a burden you bear. And you are not capable of bearing too much of that. That will quickly burn you out because it takes away from you that joy of your profession. Okay. So, on this slide, I have a lot of information, but it's not a whole lot. Let me tell you what I was trying to do here. How do you diagnose adrenal insufficiency? First, you have to suspect it. When you suspect it, you have to confirm your impression. And because a very common manifestation of Addison's or adrenal insufficiency is hyponatremia and hyperkalemia, I gave you the common causes of hyponatremia and hyperkalemia so that you don't think that every patient with hyponatremia and hyperkalemia have Addison's disease. No, there are more common causes of hyponatremia and hyperkalemia that are not related to adrenals, right? So here, I gave you what are the other causes of hyponatremia, and in nephrology, our next nephrology lecture, we'll talk about this. So these are all causes of hyponatremia that you should think about. And if you think about it, it looks like a long list, but it's nothing. Everything here, you look at the patient, you know, right? Everything here. Bile obstruction, soft tissue injury, vomiting, diarrhea, diuretic therapy, psychogenic polydipsia, SIADH. There are other things that will lead you away from Addison's here, right? And then hyperkalemia. Look at it. These are the causes of it. So basically, before you attribute hyponatremia and hyperkalemia to Addison's deficiency, you must rule out all these other causes of hyperkalemia and hyponatremia. You got that? Once you have excluded hyponatremia and hyperkalemia, and you're really thinking strongly that this patient may indeed have adrenal insufficiency, then you do the concentropine stimulation test. And that is what is in the center. You got it? Good. So basically, how do you do concentropine stimulation test? You do it to get a baseline level of ACTH and cortisol. And at 8 a.m., if you get these numbers, high ACTH level, low cortisol level, that's your diagnosis. And then you get a baseline. Then you now give them the concentropine, which is 0.25 milligrams of concentropine. The normal response is for the baseline cortisol level to double. And that is 97% sensitive and 95% specific. Okay? That is how you diagnose adrenal insufficiency. You do ACTH stimulation test. Most of the time, you are not the one that will do it. Okay? You will send the patient on to do this test. Okay? And then, if you think that the patient has other congenital, you think it's a congenital adrenal hyperplasia, then you will measure those sex hormones, LH, FSH, testosterone, DHEA, androstenedione, 17-hydroxyprogesterone. All of these are things you order if you are suspecting that this is congenital, right? So in other words, you're looking at this in somebody, a teenage boy or girl that has evidence of Addison's disease and also has evidence of precocious puberty. You think this could indeed be congenital adrenal hyperplasia. That is when you order all these other tests. Otherwise, you don't order these ones routinely. You just do the concentrated stimulation test. Okay? Remember I told you about the polyglandular autoimmune syndrome? When I told you about antibodies against Addison's, adrenals, 21-hydroxy, I told you it could be isolated to the adrenals, but it could also involve other organs. Yes. These are the two well-known polyglandular autoimmune syndromes, Whitaker and Schmidt's. You should know about this for my exam. I've never seen it in any of your exams. As a matter of fact, not even the internal medicine board do they ask this all the time. But everybody talks about it, and I thought you should know it. Okay? Whitaker is Addison's plus hypoparathyroidism. But what is it that will clue you in to have a patient that has Whitaker? These people, they tend to have hypocalcemia. What do you expect in patients with Addison's disease? Is it hypocalcemia? Hypercalcemia, right? You expect hypercalcemia in Addison's disease, right? Because of low flow, calcium is not excreted, so you get hypercalcemia. That is why Whitaker sticks out. Whenever you see somebody that has Addison's disease and then they have low serum calcium, that is so not normal to have low serum calcium in the presence of Addison's disease. So once a patient comes to you with candidiasis and hypocalcemia, that should make you think of Whitaker, because Addison's candidiasis responds to miconazole most of the time. Push come to shove, you give the pill, right? And what is that pill called? The 200 milligrams fluconazole, okay, and miconazole, yeah. Okay, so you see, that is what you treat most candidiasis with. But now here is this candidiasis that is not going away, even with fluconazole. With diflucan, it's not going away. That is a resistant one. And then the patient is showing evidence of Addison's disease and calcium is low, you're dealing with Whitaker. And I just told you what Whitaker is. It's an autosomal recessive genetic defect in the autoimmune regulatory gene. These are called AIR genes, carried on chromosome 21. Okay? It is because of these AIRE genes and their product that your body tolerates you. Your immune system is not supposed to react against you. And the reason that does not normally happen is because you have these AIRE genes that modulate immune tolerance to self. So when you have mutation in that gene, your own antibody begins to react against you. And Whitaker is one of those. And then PGA type 2 called Schmidt's, which unfortunately is more common and more problematic, presents with Addison's plus hypoparathyroidism, hypothyroidism, and diabetes. In addition to all this, they have all these autoimmune problems like pernicious anemia, alopecia, vitiligo, chronic active hepatitis. You see, this is one that is more common and is more problematic. This Schmidt syndrome is Whitaker plus. He has everything Whitaker has plus more. Because Whitaker is just what? Addison's plus hypoparathyroidism. Look at what Schmidt's is. Schmidt's is Addison's plus hypoparathyroidism, which would have been Whittaker. But in addition, he has hypothyroidism, diabetes, and he has a bunch of autoimmune disorders like alopecia, vitiligo, pernicious anemia, chronic active hepatitis. And it does not have any link to any genetic defect, right? But it is associated with these HLA antigens, okay? Again, we talk, this is secondary and tertiary, like I talked to you earlier. In secondary and tertiary adrenal insufficiency, hypotension is mediated by reduced vascular tone. Remember that, okay? Remember that, okay? So, hypotension, so this just, I'm reminding you here what you already know, right? Hypotension stimulates ADH release and water reabsorption, right? The intravascular volume expansion associated with ADH secretion attenuates the renin-angiotensin system response, right? Because remember, renin-angiotensin system is a separate system that responds to intravascular volume, and the trigger point is the renal arterial perfusion. When renal blood flow is reduced, that is when the macula densa gets information that something's wrong, the kidney is not getting perfused, and releases renin. Okay, remember that. So, if you're able to maintain intravascular volume, you will not activate the renin-angiotensin system. Are you with me? Because remember that aldosterone reclaims sodium, right? And low sodium, under normal circumstances, should trigger the synthesis and secretion of aldo. But that will not happen if that low sodium in the serum is not associated with volume depletion. Volume depletion is key because the macula densa cells respond only to low renal blood flow. If volume depletion is not present, if the renal perfusion is not compromised, renin will not be released. And if the renin is not released, aldosterone is not going to be formed. Okay? That is why I put it here that in secondary and tertiary adrenal insufficiency, you have low renin, low potassium, low aldo. And I explain it by saying renin remains suppressed in spite of low sodium because the renal blood flow is preserved. You really need to understand how the body works at important points like blood volume, blood pressure, kidneys, heart, blood vessels. They work together. You can't be confused on this. It's like a mechanic that cannot tell the difference between brake fluid and engine oil level. No, you can't be like that. You have to know what to look for when things are falling apart in major areas in the human body. There is no excuse for you not to know that. All right, and I told you already, CRH and ACTH modulate synthesis of cortisol. Cortisol increases blood pressure, not by increasing sodium reabsorption, but by enhancing peripheral vascular tone. I've said that like 4 times already this morning. Don't forget it. Cortisol levels do not affect renal sodium handling. Renal salt wasting and sodium depletion do not affect cortisol level. Okay, extremely important. Blood pressure changes in response to cortisol fluctuations have nothing to do with sodium. It has everything to do with the way the blood vessels respond to the catecholamines. Okay? So, this is a table that kind of just put everything together for you so you can see it all at the same time and understand the difference. So if somebody has adrenal insufficiency of the tertiary kind, which is the hypothalamic kind, right? The CRH, which is corticotropic releasing hormone, will be low. And because that is low, ACTH will be low, right? DHEA will be low, right? Because DHEA is the androgen from the adrenal, right? Cortisol will be low, aldosterone will be low, renin will be low, sodium will be low, potassium will be low, everything will be low, right? In the secondary, the pituitary kind, see what happens. CRH is high, right? Because the hypothalamus is trying to block the pituitary to respond, but the pituitary can't respond, so everything is low. But CRH is high. This CRH, this high CRH, exonerates hypothalamus. But when you have adrenals, CRH is high, exonerating the hypothalamus. ACTH is high, exonerating the pituitary. DHA is high, exonerating the zona reticularis, right? But then cortisol is low, aldo is low, renin is high, sodium is low, potassium is high. Renin is high. Why is renin high? Thank you, because aldo is low. When you have low aldo, you waste sodium. When you waste sodium, blood pressure will drop. Because blood pressure drops, renal perfusion will be compromised. And because the renal perfusion is compromised, the macular denser cells are going to scream. And when they scream, they spit out renin, and then the renin-angiotensin system is activated. You got that? So I explain it here again. Renin levels is high in primary renal insufficiency because renal sodium positivity attenuates renal response. ADH that compromise renal blood flow. Okay? Hyponatremia, again, I'm explaining this. Hyponatremia of primary adrenal insufficiency is due to renal sodium wasting. But that of secondary and tertiary adrenal insufficiency is due to dilution. You understand that? All right, so how do we manage all of this? Well, it depends on how your patient presents. If your patient presents in crisis, IV fluid and IV glucocorticoid replacement, and you treat the precipitating event, that's it. If the patient is stable, just give them hydrocortisone, and then you teach them to increase that hydrocortisone pill when they're under stress. So say their regular dose is 30 milligrams a day. If they get fired on their job, you tell them to up it to increase it to 45, because everybody needs more cortisol when they're under stress. Okay? And if you have evidence of mineralocorticoid involvement, you give them fludrocortisone. And fludrocortisone is what we also use for patients with hypertension. There are some people that go with low blood pressure. You have to give them fludrocortisone to, it's a mineralocorticoid, it increases blood pressure. You have to monitor, whenever you have anybody on steroids, you have to monitor their blood pressure, their blood sugar, and their serum electrolytes. Okay? For those that have congenital adrenal hyperplasia, because they tend to have some genital ambiguity, they might need reconstructive surgery. Okay? Again, I'm not going to go through the evaluation of hypopituitarism. We talked about that already. I told you about insulin tolerance test. Remember that? We evaluate for pituitary deficiency. I just repeated it here. And how do you treat it? You replace every hormone that the patient needs. Thyroid hormone, ADH, growth hormone, growth hormones. You don't do that. I've never done that. You can't do that. That is so complicated. You need all hands on deck. Send the patient to hematology oncology. They need hormone replacement, period. Now, for the tertiary, if somebody goes into a Addisonian crisis because they stop steroid suddenly, the best thing to do is to restart the steroid and then taper it off more slowly. Okay? That is really how you manage that. Now, there is something called called POTS. You might want to pay attention to this. They call testicular adrenal rest tumors. They are usually bilateral tumors. They are found in the testes. They are thought to develop from the stimulation of ectopic adrenal tissues in the testes. So, this is due to the presence of adrenal tissues in the testes. So you find the testes responding to high ACTH level. It's part of congenital adrenal hyperplasia, right? So they present like this. Why is it important that we know this? Because sometimes, remember that 11-beta hydroxysteroid deficiency, it's not associated with sexual development abnormalities, and it's part of congenital adrenal hyperplasia. Okay, so basically, congenital adrenal hyperplasia can be quiet until early adulthood, and they can present with testicular tumor. You know why this is important for you to know? Because this is one tumor that you don't need to do chemotherapy for. Steroids. With steroids, you will turn off that ACTH and that tumor will shrink. And you will look like a god in the eye of the patient. Because most of the time, most people will not think about thoughts. Okay, so you see a young adult with evidence of adrenal insufficiency and bilateral enlargement of the testis, you must remember thought. Okay? Okay, I have 10 minutes before halfway time. Let me see. Yes?
So for TARS, how do you like confirm that the person has this? It's just like
You don't need to, once you have a history of congenital adrenal hyperplasia and bilateral alignment of the testes, you just give them trial therapy with steroids. Briefly, we just shrink. Remember, it's part of the manifestation of congenital adrenal hyperplasia. Okay? Any more questions? Okay, so let's see what we can do in 10 minutes. I think we can cover this. So now, remember I told you that Addison's disease is typically called hypocortisolism, right? Now, when you have aldosterone deficiency, it's part of adrenal insufficiency, but now more specifically, aldosterone is missing. And the reason this is the case is, the reason we talk about this on its own was because I told you in my first 2 slides that renin-angiotensin system exert more influence on aldosterone synthesis and secretion than the hypothalamo-pituitary adrenal axis. I told you that. Right? Remember that? Good. So you really don't find a lot of cortisol manifestations in hypoadrenalism, in hypoaldosteronism. It presents like a totally different disease. That's why I'm going to talk about this separately in the next 10 minutes. So this is aldosterone deficiency without cortisol deficiency. There are 2 types. There is the hyporenemic and there is the hyperenemic. The hyporenemic type is the renal tubular acidosis type 4. The last thing I'm going to talk to you about in nephrology is renal tubular acidosis. So just know that there is something called renal tubular acidosis. Okay, and there are 3 types actually: type 1, type 2, type 4. Don't ask me about that 3. Right. So when aldosterone is deficient, it could be due to because renin is deficient, which you'll expect because renin is the initiator of aldosterone response, right? So if renin is not there, you don't expect aldosterone to be there, right? Then it could be hyperenemic. In other words, this is a aldosterone deficiency that the macular denser cells are trying to correct because they sense it and they can respond to it. Now, what are the causes of hyporenemic hypoaldo? Look at them. This long list here looks like a very long list. But you know what? Take a good look at it. All chronic kidney disease will give you eligible for renal tubular acidosis type 4. Diabetes in and of itself does not give you RTA type 4. It is when it has caused diabetic nephropathy. Right? So, type 4 RTA is common in all chronic kidney disease. So don't memorize the list. Just remember that RTA type 4 is a manifestation of chronic kidney diseases, lupus, anaplastic nephropathy, multiple myeloma, when it affected the kidney, IgA nephropathy, nephrolithiasis, glomerulonephritis, obstructive neuropathy, sickle cell nephropathy, all of them can cause RTA type 4. And then there are medications that we give that inhibit renin production, like beta blockers. They block the sympathetic nervous system, right? And you know that the renin-angiotensin system is wired close to the sympathetic nervous system, right? So when you block the beta receptors, you also do the same thing. And then you have inhibitors of renin release itself, like NSAIDs. So these are causes of RTA type 4. Now look at the hyperenemic ones. It basically is mostly drugs. Aldosterone synthase deficiency is a rare disease. It's due to enzyme deficiency. I've never seen it. I've heard about it all my life. I've just seen it. You're not likely to see it. Then look at the rest of the causes of hyperaldo. Renin inhibitors, aliskiren. Remember all these blood pressure medication we're talking about? ACE inhibitors, ARBs, aldosterone antagonists, spironolactone, proinone. All these epithelial serum channel blockers, triamterene, amiloride, trimethoprim, Bactrim, pentamidine. What do we use pentamidine for? Vinny told us this, like for we use it for PCP, for what else? A parasitic disease. Thank you. And it causes, it is very toxic to the beta cells, right? And one because of hypoglycemia, of insulin excess. Remember that? Talk about that in hypoglycemia. Oh, that was when you're getting ready for your midterms. So you didn't remember. Okay. And then cyclosporine. Do you see that hypoaldosteronism can be hyperenemic when it is mostly drug induced, or it can be hyperenemic when it is due to chronic kidney disease? So this big slide that looks so complicated is not. All you need to do to remember everything here, just know three things. Hypoaldosteronism is usually due, it could be due to, it's aldosterone deficiency, of course, you know that. It could be due to hyperenemic or hyperenemic. Hyperenemic is drug induced. All of the RAS inhibitors, whether they inhibit renin, aldo, whatever, RAS inhibitors, the hyporenemic ones are chronic kidney disease from whatever cause. Diabetes, sickle cell disease, prostate, whatever. Chronic kidney disease, and that is also known as type 4. So remember now, don't forget it, because I'll ask you in nephrology. Type 4 RTA is hyporenemic hypoaldosteronism. Hyporenemic hypoaldosteronism equals type 4 renal tubular acidosis. Okay. Let me explain to you why it's called renal tubular acidosis now. Remember we said that aldosterone reclaims sodium at the expense of potassium, and when the body doesn't have potassium, you start doing it at the expense of hydrogen. Right? When you don't have aldo, you can't get rid of hydrogen ions. Right? And because you have developed acidosis, that is as a direct result of the inability of the kidney tubules to secrete hydrogen ions, it is called renal tubular acidosis. Okay? And specifically in type 4, it is due to the absence of aldo. That is why type 4 RTA is exactly the same thing as hyperenemic hypoaldosteronism. Type 1 is due to deficiency in the proximal convoluted tubule, and type 2 is a deficiency in the distal convoluted tubule. Okay. But we'll talk about that in nephrology. I just want to demystify it for you now so you don't get confused about it. Okay? So, whenever you see somebody, and this is one thing I won't won't fault you if you don't know it, but I will test it in your exam, and I know nobody else will ask you about it. Okay, because this is nephrology stuff. Okay, nephrology stuff like this. But you need to know. I just think you should know some things because I am your instructor. Okay, I just think you should know. Now, how does hypoaldosteronism present? Like I said, hyperkalemia and metabolic acidosis. You expect that, right? And you're not surprised that urine sodium will be high. Are you surprised? Aldosterone is responsible for sodium reabsorption. If it's not there, urine sodium will be high indeed. Sodium will not be reabsorbed, it will be high in the urine, right? And you expect urine potassium to be low because it's not being secreted, right? So this is not surprise. But does that then mean you can diagnose everybody with hyperkalemia, metabolic acidosis, high urine sodium, and low urine potassium with aldosterone deficiency? No. There are other things that can cause this. A good example, if somebody, for instance, is having diarrhea, right? If they're having diarrhea and they're drinking a lot of orange juice because they think they're having diarrhea, they will have metabolic acidosis, right? From diarrhea, right? They will have a hyperkalemia from the orange juice they keep drinking, right? Yeah, urine sodium might not be high, but for sure urine potassium will be low, right? It's not specific enough, but it is good enough to kind of set you to suspect that this could be indeed hypoaldosteronism. How do you diagnose hypoaldosteronism? Ideally, you really want to compute what is known as transtubular potassium gradients. This gradient is calculated. It is used to assess renal potassium secretion at the cortical collecting duct under the influence of aldosterone. One of the first few things I said to you this morning is that the target for aldosterone is the collecting duct portion in the cortex known as the cortical collecting duct. So if you really want to know is aldo present or absent, you look at what the cortical collecting duct is doing, right? And how do you do that? You look at the ability of the cortical collecting duct to secrete potassium in response to aldo. You look at the ability of the cortical collecting duct to reclaim sodium at the expense of potassium. And the way you assess renal potassium secretion is by computing the transtubular potassium gradient. How much potassium is on this side of the tubule, how much is on this side of the tubule. So you look, if the tubules are working, the gradient under normal circumstances should be anywhere from 6 to 9. If the gradient is less than 6, in somebody with hyperkalemia, something is wrong. That right there is telling you this patient has adrenal aldosterone deficiency. So I'm not expecting you to understand the mathematics and everything, but at least you should know one thing. You should know about TTKG, transtubular potassium gradient. You should know that it assesses the ability of the cortical collecting duct to secrete potassium. And you should know that normally it's between 6 to 9. And when it's less than 6 in somebody with high serum potassium, something is wrong. Those three things you must know. And that's what I will test. No more than that. Okay? You might just want to remember that that formula that we use to calculate TTKG is valid only when urine osmolality is normal and urine sodium is at least more than 25 milliequivalent per liter. If the patient is dehydrated, that formula breaks down. Okay? So you will never have any reason to compute this in practice, but I will ask you, and I don't know who else might. Okay, but I also want to be able to at least, in any conversation on your internal medicine rotation, people are talking about hyperkalemia, they're talking about TTKG. You know what TTKG is. And nobody will expect you to know that. Okay. All right. So hypo, like we talked about hypocortisolism, he has his own differential diagnosis. Remember when we talk about Addison's disease, we talk about polyglandular endocrine syndrome, type 1, type 2. The same thing, hypoaldosteronism has its own differential diagnosis called pseudo-hypoaldosteronism. This is another area you don't really need to. This is FYI, okay? So whenever you diagnose somebody with aldosterone deficiency, remember that aldosterone deficiency could be a false aldosterone deficiency. When would you suspect pseudo-hypoaldo? When your patient does not have any chronic kidney disease, right? When your patient is not taking any renin-angiotensin system inhibitor medications. Those are the two things that are responsible for hypoaldo, right? So if you see hypoaldo in somebody that doesn't have any chronic kidney disease and is not taking any RAS inhibitors, then that is your clue right there that this could indeed be pseudo-hypo. And there are two types of it. I've given you the information. We'll talk more. Of course, we cannot avoid talking about Gordon, chloride shunt, and Liddle syndrome in nephrology, but I'm introducing the topic here for you to know. Type 1, right, is autosomal recessive, and it's a mutation of that sodium channel. I don't want to bug you now because I'm afraid we have a lot to talk about. Mark this slide, you will see it again. All I can say. All I want you to remember here right now is when should you think about pseudo-hypoaldo? Whenever you see hypoaldo in somebody with normal kidney functions who is not taking any medication that interferes with the renin-angiotensin system. Okay? And pseudo-hypoaldosteronism can be of two types, type 1 or type 2. Okay? That's what I need to know right now. Okay. So how do we treat hypoaldo? We treat hypoaldo by treating the hyperkalemia. That is the most dangerous part of it. What will hyperkalemia do to you? It stops your heart in diastole. So you have to worry about it. How do we treat it? It's very simple. We do three things. We shift it, we get rid of it, and we protect the heart. Protection of the heart is called membrane stabilization. How do we do that? We give calcium gluconate. And before we used to give hypertonic, but now the real deal is calcium gluconate, 10%. You give it over 10 minutes, 10 minutes. You give it, it begins to work immediately, and it protects the heart for at least an hour. Okay? So when somebody has hypokalemia and they're flipping PPCs and going into beta short runs, you better make sure you give them calcium gluconate to protect the heart. Okay? Then once you protect the heart, you give them something to shift the potassium into the cells. And the way we do that is Adrenal. Okay? It's a beta stimulant, beta agonist, right? One of the things they do is to shift potassium from the extracellular compartment into the intracellular compartment to limit the impact of hypokalemia, right? And then you can also give insulin. And if your patient becomes hypoglycemic, you give them glucose. The idea is whenever you give somebody insulin, insulin will drive the glucose into the cells, right? Well, in order for the cell to keep taking glucose, it has to convert that glucose into glycogen, right? And that process requires potassium and phosphate. That's why when you're treating patients with DKA, you keep your eye on potassium and phosphate, because you're going to be driving them inside the cell along with it, because that anabolic activity you're stimulating with your insulin is going to be taking up phosphate, because they're going to be forming ATP, right? You're going to be taking up potassium. So you keep your eye on the serum potassium, because you might be busy trying to control blood glucose and you drive the potassium so low, you put your patient in B-field and then you end up with a pulseless tachycardia. That is a big deal for you. Okay? So we shift potassium and then we excrete it. How do we excrete it? You give Lasix, sodium bicarbonate, and then you give this sodium polystyrene sulfonate called K-Xylate. It's called cation exchange resin. What K-Xylate does is you give it by mouth, it goes in the colon, right? And it begins to trade sodium potassium, right? So it basically just exchanges potassium for sodium. It takes potassium out of the blood and they dump sodium. So it's called cation resin exchange. It does it from the colon. And the complication, of course, is diarrhea. Believe me, diarrhea is better than hyperkalemia. But good news is that there is a new medication called Potiroma of Beltazar, recently approved by the FDA, that everybody now uses to control hyperkalemia in patients with hypoaldosteronism. Okay? Good. I think that's it. We did it in a little over 10 minutes. So you want a break? I know you do want a break, right? Threatened by hyperkalemia. That's an emergency. You have to give them calcium gluconate, you have to give them albuterol, you have to give them all that. But if it's a routine clinical encounter, or say for instance the lab called you on a Sunday night that your patient potassium was 6.8. You log into the system, says, bring this patient in ASAP. I want to see the thing on Monday. Patient comes in on Monday. You go to the lab, say the potassium is 6.8. But on Monday, when you're doing the EKG is fine. So you go with your EKG. So that means the potassium is high, but patient, I can manage this on my own right here, right now. You review the medication, you stop all renal angiotensin system drugs, right? You start Lasix, right? You tell them go back to the lab in 1 week. Come back and see me the following week. You now look at the numbers, right? You understand what I'm saying? So it's not, this is what all that you will do, but you don't do everything every time in everyone, no. You based on your clinical judgment, your patient presentation. You all understand that? Okay, so why don't we take a break for 5 minutes so we can continue this how differential diagnosis of hypoaldosteronism and Addison disease. You remember that? Don't forget that. So now let's go to hyperaldosteronism. So hyperaldosteronism is excessive synthesis and secretion of aldo. There are 2 types of it, primary and secondary. But again, this is now different, you see, because under normal circumstances, right, for all of the endocrine stuff we talked about, when we say primary, it has to do with the end organ. And when we say secondary, usually mean the pituitary, right? But in this case, that is not really true. Primary, yes, is due to the adrenal problem. Secondary is due to something else. Okay? So when we talk about hyperaldosteronism, it could be primary or secondary. Primary, it is usually due to idiopathic hyperaldosteronism. In other words, the adrenal gland is just overworking for whatever reason. Okay, we don't know why. That's why it's idiopathic. What we don't know, I think it should be ignorant. It should call ignorant about it. But we don't like to call ourselves ignorant. So we use the word idiopathic to cover our own ignorance. Right? The most common cause is idiopathic adrenal hyperplasia, called idiopathic hyperaldo. The second most common cause is an adenoma in the adrenal. Okay? There is this rare, weird cause of hyperaldo. Remember I told you that the zona glomerulosa and the zona fasciculata they are different. Fasciculata, where cortisol is produced, responds to ACTH. And the glomerulosa, where aldosterone is produced, responds to renin-angiotensin system. Right? That is because that is the way they're supposed to be wired. But there is a particular mutation called chimeric mutation that put part of the gene that belongs to the zona fasciculata onto the genes of the cells in the zona glomerulosa in such a way that aldosterone synthesis and secretion is now subject to ACTH production. That should never be the case, right? Because under normal circumstances, aldosterone synthesis and secretion is supposed to be controlled by the renin-angiotensin system, not by ACTH. But because of this mutation, aldosterone synthesis and secretion is now subject to ACTH modulation. You know what happens, right? So that gives you excess aldosterone production, and the patient becomes hypertensive. You know what is cool about hypertension? You control it with steroids, right? Because steroids will suppress ACTH. That's why it's fun. It's a rare disease, but it's so intriguing that, my goodness, I could steroid. We never talk about steroid for treating high blood pressure. We always talk about steroid for causing high blood pressure. But here is what is called, glucocorticoid remediable hypertension. It's due to that chimeric mutation where you have hybrid glomerulosa cells that are responsive to ACTH, right? So at the end of the day, through all these three mechanisms, you form aldosterone excess. And aldosterone does what it does: reabsorb sodium, expand the intravascular volume, cause hypertension, dump potassium. That's what it does. And that's how all of this happens. You got that, right? Are you all clear about that hybrid chimeric mutation I told you about? You understand how that could work, right? Good. So this is primary hyperaldo. Primary hyperaldo, there is no reason for it. The adrenals are just crazy and they're putting out aldo more than the body needs. So they cause hypertension. Now the secondary hyperaldosteronism is usually due to intravascular volume depletion. So whenever intravascular volume drops and renal perfusion is compromised, the macular denser cells are going to turn out renin that will ultimately cause aldosterone to be secreted. That is what is known as secondary hyperaldosteronism. So the causes of it are the causes of volume depletion. Now, volume depletion can be covert. In other words, your patient can be volume depleted in a very healing way. Small bowel obstruction. How do you diagnose small bowel obstruction? On an X-ray, you see multiple air fluid levels, right? Do you know that those fluid levels you're looking at in bowel obstruction, they are trapped in the bowel? They are not accessible to the intravascular space, but they're there in the bowel. So your patient with small bowel obstruction, they are volume depleted, not because they're swollen, not because they're vomiting, not because they're having diarrhea, but body fluid is trapped inside the bowel. It's not available in the intravascular space. That is one mechanism for volume depletion, covert kind. Soft tissue injury. When you rescue patients from people with extensive burn, right? Extensive burn where all the tissues, or rhabdomyolysis, where all the tissues are inflamed and they have inflammatory edema. You can lose intravascular fluid into the extravascular, specifically interstitial space, in such a way that within the blood vessels, blood is not enough because you're losing it into the extravascular space. In this case, your patient is not having diarrhea or vomiting, so you're not seeing the volume loss. It's a covert volume depletion. Then you have pancreatitis. You remember pancreatitis? You remember Gray Turner and Collins syndrome?
Yeah.
That is, do you know how much volume is in your retrospinal space? In your retroperitoneal space is an extensive space, narrow but extensive. So you can hold a lot of fluid. So patients can bleed into that retroperitoneal space and be depleted of volume within the vascular space, and you will not see it. That is why we appreciate Gray Turner and Collins in science, because they allow us to see who this patient is losing fluid. And then peritonitis. I mean, seriously, there is so much cavity in the peritoneal space, you can lose a lot of fluid into it. So volume depletion can be covert or overt. Overt is your vomiting, your gastric aspiration, the diarrhea, your enterocutaneous fistula. You all know what enterocutaneous fistulas are, right?
Yeah.
Good. It's where your bowel opens to the skin. Sometimes we bring it, sometimes the disease will cause it. Okay? And then, edematal state, cardiovascular disease, congestive heart failure, inferior vena cava obstruction, superior vena cava obstruction, portal hypertension. All of these situations that make patients swell. Whenever your patient is edematous, that means they have a lot of fluid in their interstitial space. That fluid is coming from your intravascular space. So all of these patients with volume depletion and edematous states, they will have intravascular volume depletion. Okay, because they're losing fluid from the intravascular space to the extravascular space. And because they are depleted in their intravascular space, the renal perfusion is going to be compromised. And when renal perfusion is compromised, the macular denser cells are going to release renin, and you're going to get hyperaldo. That is a normal response. So secondary hyperaldosteronism is a normal response to intravascular volume depletion, right? Whereas primary hyperaldo is a useless response. It's not. It's a condition where aldosterone is increased, and there is no reason for it. Okay, are you clear? Excellent. So this is what I'm trying to explain here. In primary, you have increased intravascular volume because aldosterone production has gone cuckoo. Right? It's just aldosterone is being put out there, and aldosterone is going to the kidney, reclaiming sodium, expanding the intravascular space, and it won't stop. It just keeps doing it. So you get increased intravascular volume, increased sodium retention, you turn off the renin, right? And increase aldosterone production. So you see the initiating event in primary aldosteronism is increased aldosterone production. Whereas the initiating event in secondary hyperaldo is reduced intravascular volume. Okay, you understand that? That is extremely important. So how does it present? Primary will present with hypertension, and because of the intravascular volume expansion, you don't get the nocturnal dipping that you normally get. Under normal circumstances, blood pressure drops when you're sleeping. And because of the increased intravascular volume, you don't drop your blood pressure during sleep anymore. So that nocturnal dipping is gone. And of course, because aldosterone is causing you to retain sodium at the expense of potassium, you get hypokalemia. And of course, when your potassium stores are depleted, the same aldo will start doing it at the expense of hydrogen ion, right? So you go into metabolic alkalosis, right? When you develop metabolic alkalosis, you're not going to be filtering bicarb. Now, because bicarbonate is negatively charged, right? And sodium is positively charged. Excess bicarb in the tubules will hold on to some sodium and fight back against aldo. So that is why urine sodium is high in primary hyperaldo. Are you with me? Stop typing, think. What I just told you, if it is under normal circumstances, when you have excess aldo causing sodium retention, you expect urine sodium to be low, right? Because that's what aldosterone wants. It wants to reclaim all the sodium. But in primary aldo, urine sodium is high because the metabolic alkalosis causes excess bicarbonate, right? And that bicarbonate, because it's negatively charged, will hold on to some sodium and escapes with it. That is why the urine sodium is high in primary hyperaldosteronism, in spite of increased level of aldo. Okay? And of course, chloride follows sodium wherever it goes. So urine chloride is also low. This is very important. Okay? Now look at secondary hypoaldo. They get orthostatic hypotension. So they get a narrow pulse pressure, less than 30, systolic blood pressure, less than 20. You know that I'm just telling you what positive orthostasis is, right? So when your patient changes position, their systolic blood pressure drops by more than 20, their systolic blood pressure drops by more than 10, or their pulse goes up by 20. Any one of those will give you a positive orthostatic changes. Remember we talked about that, right? Right?
Yeah.
Okay. So then you get hypokalemia, and then you get metabolic alkalosis. But because of the volume depletion, urine sodium in this case is low, and urine chloride is low. Extremely important. I'm trying to explain to you here that high flow alkalosis mediate increase in urine and potassium, right? But when there is volume depletion, that does not happen. The body has a way of overriding abnormal physiology. When you have volume depletion, when the intravascular volume space is shrinking, the body does not lose sodium. That is why urine sodium is one of your most sensitive index for volume status. You look for urine sodium. If your urine sodium is low, something is wrong. You need fluids. Okay? So pay attention to the difference between the presentation of primary aldo and secondary aldo, especially when it has to do with the urine sodium and chloride. It is high in primary, it is low in secondary. Extremely important. I can't say that enough. So, whenever you see somebody you suspect they have hyperaldo, you're going to measure two things. You're going to measure the plasma renin activity, and you're going to measure the plasma aldosterone concentration. How do you interpret or evaluate those two parameters? So when you suspect, pay attention, when you suspect hyperaldosteronism, you measure renin activity and you measure aldosterone concentration. Okay. You already know your patient has excess aldo. If your renin activity is high and your plasma aldo is high, then you're dealing with a renin-angiotensin system dependent aldosterone mediated mineralocorticoid excess. You got that? If when you measure plasma renin activity and aldo, both of them are elevated, that tells you that mineralocorticoid excess you're looking at, that hyperaldosteronism. Remember, I'm using the term mineralocorticoid excess because patients with hyperaldosteronism don't necessarily have aldosterone excess. They could have other mineralocorticoids that are driving that symptomatology. Okay? So generally speaking, what we like to talk about when we talk about hyperaldosteronism, we talk about mineralocorticoid excess. Although when we call it hyperaldo, it conveys the wrong impression that the only source of mineralocorticoid excess is aldosteronism. It's not always the case. There are other precursors that also have mineralocorticoid activities. Okay? So, what I'm saying to you is, when you measure plasma renin activity and plasma aldo concentration, and both of them are high, the conclusion you're going to draw is that hyperaldosteronism or that mineralocorticoid excess is renin-angiotensin system dependent, and it is aldosterone mediated. And that tells you that that is most likely a secondary hyperaldo, right? But if your patient does not have any evidence of volume depletion, they are not vomiting, they are not having any edematous states, then you have to look for a salt wasting nephropathy. A salt wasting nephropathy is a kidney disease that is associated with inability to reabsorb sodium. Okay? So we call them salt wasting nephropathies. Patients are usually born with them. And they are very popular in medicine for obvious reasons, right? The two common ones are Bartter's and Gilman syndrome. I've never seen one of these. But you know why we like talking about it? Because Bartter's syndrome, your patient presents as if you've given them loop diuretics. Because the abnormality in Bartter's is the target of Lasix. So somebody with Bartter's syndrome will present as if they're taking diuretic therapy, specifically Lasix. But they're not. And then Gilman syndrome, because the problem is in the distal convoluted tubule, they behave as if they are on thiazide diuretics. So you just need to remember that Bartter's syndrome is one of those salt-wasting nephropathies that present as if the patient is on Lasix. And Gilman syndrome is one of those salt-wasting nephropathy that presents as if the patient is on thiazide diuretics. Okay, they are both due to inactivating mutation of the sodium transport system in tubules. Okay. So why am I telling you this? I'm telling you this because salt-wasting nephropathy is a differential diagnosis of hyperaldosteronism. That's why the title of this slide is Differential Diagnosis of Hyperaldo. Okay? So if your patient has evidence of secondary hyperaldo, but they are not losing volume and they are not edematous, you think this could be one of those salt-wasting nephropathies. Okay? You must know this one. And then, supposing you do the plasma renin activity and the plasma aldo concentration, and they are both low, the conclusion you can draw from that is that mineralocorticoid excess is not RAS dependent and is not mediated by aldosteronism. It's not mediated by aldosterone. Well, if it is not mediated by aldo, what else could mediate it? Deoxycorticosterone that is formed in excess in patients with 17 alpha and 11 beta hydroxylase deficiencies. They can mediate sodium reabsorption and cause mineralocorticoid excess. They will even suppress renin and they will suppress aldo. That is why both the renin and aldo concentrations are low, and yet your patient is showing clinical evidence of mineralocorticoid excess. And the way you will know that is that both renin will be low and plasma aldo will be low. That tells you that that is indeed a renin angiotensin independent, non-aldosterone mediated mineralocorticoid excess. So in other words, this mineralocorticoid excess had nothing to do with aldo. Okay? What else can cause it? Cortisol. Remember cortisol, under normal circumstances, cortisol is supposed to be inactivated once it has stimulated its receptor by 11 beta hydroxysteroid. Remember that? But if you are in the habit of ingesting licorice, then your cortisol will linger longer at the receptors. And when you begin to stimulate mineralocorticoid receptors, and it's cortisol doing it, right? Because of this abnormality. And then there is this congenital problem called Liddle syndrome. We'll talk about in nephrology. That is a mutation of the sodium channels, right? Under normal circumstances, INACs, which are the epithelial sodium channels, they are supposed to reabsorb sodium only under the influence of aldosterone. But when you have an activating mutation of INACs, then they reabsorb sodium regardless, whether or not aldo is present. And that congenital anomaly is called Liddle syndrome. They present with hypertension and all that stuff. We'll talk about that in nephrology. I'm just mentioning it now. Are you with me? Everybody good? All right. Now, when you measure plasma renin activity and plasma aldo concentration, and the renin activity is low and the aldo is high, now that is what you're talking about. You're now talking about a renin-angiotensin system independent aldosterone mediated mineralocorticoid excess. That is the way your primary aldo presents. It presents with low renin, high aldo. And that makes sense. under normal circumstances, aldosterone synthesis and secretion is supposed to happen under the influence of renin. If it is happening in the absence of renin, that means the adrenals have gone rogue. Okay. That is why when you do renin activity and aldo concentration, what you're looking for in primary aldosteronism, that is also known as Cohen's syndrome, is low renin and high plasma aldo concentration. Okay? And it's so good that when you look at that ratio, and the ratio is more than 30, that is highly, highly suggestive of primary hyperaldo with a sensitivity of 90% and a specificity of 91%. Okay? Once you have established that, you send your patient to the endocrinology. They now do confirmatory tests, and they can do all kind of tests, aldosterone excretion rates, saline loading tests. They can do all kind of tests to confirm the impression of primary aldo. That you don't have to worry yourself about. Just know how you interpret plasma aldo and plasma renin activity. You must know how to interpret them. Okay? So this is just a diagram to kind of tell you how you might proceed. So you confirm that somebody has primary aldo. Basically, you want to decide, is it idiopathic adrenal hyperplasia, or is it due to an adenoma, or is it due to that chimeric mutation? And you do all kind of stunts to figure out what is going on, including what is known as adrenal vein sampling. You know what they do in adrenal vein sampling? They go from the groin and they go to the adrenal veins on this side and on that side, and they sample them and they compare the aldosterone level. If the aldosterone levels are comparable, that means the patient has adrenal hyperplasia, right? But if the aldosterone level is higher in one than the other, that means the patient has adenoma. Okay. So they do all these stunts, but ultimately the goal is, once you diagnose adrenal hyperaldosteronism, you ultimately want to decide what the patient has. The endocrinologist must differentiate between hyperplasia and adenoma. You know why that is important? Because hyperplasia, you have to treat with medication. Adenoma, you have to send to surgery. Got that? So how do we treat it? Aldosterone producing adrenal adenomas called APA account for 40% of the cases. You do surgery, unilateral appendectomy, blood pressure control improved in all, but hypertension is cured only in less than 50%. So somehow, something happens when you have hyperaldosteronism and you stretch the intravascular volume, intravascular space. Even when you now take away the tumor, the hypertension doesn't go away in more than half of the patients. Okay? So remember that. You do surgery. When it is bilateral adrenal hyperplasia, it accounts for 60%. You just give them mineralocorticoid receptor blockers. Right. And remember the one I told you about the chimeric mutation? You give them dexamethasone to treat hypertension. Seriously? That tickles your brain when you hear it. Dexamethasone to control blood pressure? How does that work? Right? You got this? Right? Okay. Any questions on this one? Are you with me? Good. Cushing syndrome. You know about Cushing syndrome because I talked about it as a differential of Cushing disease in pituitary disorder, right? Only this time it is due to Cushing syndrome. 70% of the time it is due to Cushing disease, right? You know that. Then 10% of the time is due to an ectopic ACTH. And 1% of the time is due to hypothalamus putting out excess corticotropin, right? Another 10% of the time it is due to adrenal adenoma, 5% of the time adrenal carcinoma, and 4% of the time we don't know what the heck it is. We know something in the adrenal is causing it, we don't know what is causing it. Okay. So Cushing syndrome is all of this put together, right? How does it present? You know about this. You've talked about this so many times, right? Either before you got here, I don't know if you talk about it when you got here, but this is what it is, right? Truncal obesity, skinny legs, fat trunk, and buffalo humps, and easy visibility, brittle bones, and all this stuff that we talk about in Cushing's. Is there anyone here that has not heard about Cushing syndrome before? Anyone here that does not know how Cushing's manifest? Do I need to go through that list? Talk to me, people.
No.
Thank you. Right? So this is like, but remember some keywords, right? Buffalo humps, moon for sheep, truncal obesity, osteoporosis. Those are key. Okay? So whenever you hear those words, moon face, buffalo hump, those are important keywords you must recognize. Okay? So, I'm so proud of myself. This book, this figure right here, was a figure I developed when I got invited from this guy in England. He was writing a book for cardiology fellows. It's a cardiology book. And they were talking about secondary hypertension. So they invited me to write a chapter on secondary hypertension. And I developed this figure. And it's out there somewhere. Whenever I look at it, I realize, I've done something. Good. So whenever you think about Cushing syndrome, right? The first thing you want to do is 24-hour urinary free cortisol. So that's the way, because cortisol level fluctuates from time to time during the day. We don't know when should we take the blood. Because if you take the blood in the morning, it will be high. If your patient goes to the lab in the afternoon, it will be lower. If they go on their way from work, it will be even lower. So we don't know what is normal. So we don't worry about what the serum level is at any given time. We collect 24-hour urine for cortisol. That is a lot better for us. So we do 24-hour urine-free cortisol. And you only worry or think about it if that 24-hour urine cortisol is more than 100 micrograms per mil. But patients don't like to carry urine up and down. Sometimes they're on the bus. Right? How would you feel somebody in the bus carrying this bag of urine? Right? Oh, you got that? Do you mind? So I was kind of like, people were like, nah, it's not good. Let's look for other ways. Then they came up that it turns out that if you can draw the cortisol in the middle of the night, would you let somebody in your house in the middle of the night to say, hi, I'm from the lab. I'm here to draw your blood for cortisol. Would you open your door? Especially with ice agents all over the place right now. Nobody will open their door, right? So the only time we do this is if this is happening in the hospital, right? If it's happening in the hospital, the phlebotomist can go to the bedside and draw the blood right there in the hospital. You don't send anybody to anybody's home to draw cortisol level in the middle of the night because you're thinking of cortisol. You don't do that, okay? Don't do it. Other times you will say, okay, fine, why don't you spit in this bottle and drop it off in the lab in the morning? So we do late night salivary cortisol assays. That will do it. They are relatively new techniques. What I still do, and I recommend that you do, until we know more about this midnight and late night salivary cortisol and serum cortisol level, is do 24-hour urine cortisol. You spit.
Like just
Regular spit.
no, I know, but is it like a bomb?
They give you a container.
Oh, yeah, so I just
You just spit it in and fill it and cover it up. Okay. All right, so now when the patient now submits, when the patient is taking that urine to the lab, that morning they will now take their plasma ACTH. So now, this is how you now go. If your ACTH level is low, in that morning, you have a problem. Okay? Because under normal circumstances, your ACTH should be high and your cortisol level should be normal. It should be normal, it shouldn't be low. Normal. So if ACTH is high, ACTH is low, that means ACTH is being suppressed by abnormal cortisol production. Okay? That is why you notice that when ACTH is low, you go straight to do abdominal CT or MRI because you know something is wrong. Okay? Now, if ACTH is high, well, you know that already. If ACTH is high in somebody that looks like they have Cushing's, that is Cushing's disease. We already talked about that, right? We'll talk about dexamethasone suppression test. Remember all that? When we're talking in Cushing's disease, when we talk about pituitary. So that is that. That's why I'm not going to dwell too much about that. And when ACTH is normal, now you have a problem. Because a normal ACTH level in somebody that looks like they have Cushing's syndrome does not exclude Cushing's syndrome. It just means Cushing is hidden. You have to dig deeper to look for it. It's only when your ACTH level is normal in the presence of overt Cushing syndrome that you do the corticotropin infusion test, where you take the patient into the hospital, infuse corticotropin, and see the response of ACTH and cortisol to it. You don't do that otherwise. You only do it when ACTH is normal. Okay? Moving on. And this is the dexamethasone suppression test. We talked about this already. You've seen this slide before. Remember high dose, low dose, right? And overnight. We talked about this, right? Okay. Just want to make sure. And you've seen this slide before. Dexamethasone suppression test is very useful, it's very helpful, but there are times it could be falsely suppressed and false non-suppression. These are all related not to Addison, not to Cushing syndrome, but specifically to Cushing's disease. And we talked about this in pituitary class. You remember, right? You remember?
Yes.
Marie, you remember?
Yes.
But you can use some revision.
Yes.
How do we treat Cushing's? Well, I'm repeating myself here because I will feel odd talking about Cushing's syndrome without Cushing's disease. But I know I talked about Cushing's disease already, and I really don't have a lot of time. We still have some stuff to cover. So I'm not going to repeat myself. We talked about this. This is how you treat Cushing's disease. Remember the transperineal surgery? Right? We talked about that?
Yeah.
Okay, good. And then this is how you treat it when it is due to adrenal problem. See, you do somatostatin analogs, P450 inhibitors like ketoconazole. You have enzyme inhibitors of those enzymes, retinoid, mitotane. Then the newest one is this mifepristone. These are anti-cortisolic drugs. Okay, I just need you to know a few of them. Of course, you have to know the major classes: somatostatin analogs, pasireotide, P450 inhibitors, ketoconazole, but anti-cortisolic. Nobody really drills you on these ones. I've not prescribed any one of these medications before, and I've been practicing medicine for 20-some years right now. How long have I been practicing medicine?
27.
I left medical school in 1989. So about 20-something years. So I've not prescribed any one of them. So you're not likely to do it. Just know that once you see Cushing syndrome, you differentiate between Cushing's disease versus adrenal problems. Cushing's disease surgery. Adrenal problems, anticortisolic medications, including ketoconazole. Okay. That's all I would expect you to know. Ah, good. That was a good one. Questions? Are you good? Are you tired? I'm overloading you, right? Do we have a lot left?
No, you have 6 slides.
6 slides?
Mhm.
So we're done very soon. We have a lot of time. So I have some refreshing questions at the end. Right. Okay, let's do it. Pure chromocytoma. This one. Pure chromocytoma. Pure chromocytoma is a tumor of the chromatin cells in the adrenal glands. They are individual. Okay? They are innervated, like I said, by the preganglionic fibers. They function as a modified ganglia. We talked about this already. They send progress signals to nearby cells. That is why they're a neuroendocrine tumor. That's what they call them, neuroendocrine. Chromatin cells are found not only in the adrenals, you find them in the liver, in the bladder, you find them along the vagus, you find them even along the carotid. That is why pheochromocytoma is a sneaky bastard. Once ever you see it, you can never nail it down. It's so troubling. It bothers the patient and you don't know where it is. It's hidden and it's releasing these hormones into the circulation, and your patient is distressed by it and you can't find the son of a gun.
Have you ever
You
found
keep
one?
looking. Yes, that one I've seen. And it's distressing for the provider and for the patient. Because the patients, this way in this country, patients come to you like you're supposed to have the answers. And they get very angry when you don't come up with the answers. In other parts of the world, people understand that doctors they don't have all the answers. Because doctors are the first to tell you, we don't know what is going on. I think we should seek home solution. And when doctors tell you in many countries to seek home solution, they tell you to turn spiritual. Because they understand that they are limited. But in America and in England and all this Western world, there is this false impression that we know everything. So we have conveyed the wrong impression and convinced people that we have all the answers. So when they come to us and we're like floundering and not able to answer their question, they get really upset. And I'm not embarrassed to tell my patients, look, I don't know where this tumor is. Okay? Pray. Maybe God will show it to you. And you're like, pray? I'm like, yeah, pray. Do you know the guy that opened up the petrochemical industry? Have you heard about Kekule? When the structure of benzene was determined as C6H6, everybody knew that benzene was C6H6. We knew enough about radiochemistry to know how can there be a stable molecule that contains 6 carbon atoms and 6 hydrogen atoms. It's not possible. We know the valency of those elements and nobody could figure it out. Kekule went to bed distressed about this. And in his sleep, he had a dream where he saw a snake biting his tail. He woke up from that sleep and said, the benzene structure is a ring structure. The benzene structure is a ring structure. Went to his board, draw the structure of benzene, opened the entire petrochemical industry. It was from a dream. So don't think that we're in control of this thing. We're not. There are forces that determine what we know, when we know it, and how we're going to know it. So when I tell my patients, look, I don't know where this stuff is. Pray. We should do it. And what? I can tell you stories. It is the reason I opened that answer prayer there, where I invite my patients. Technically, I have to go to the church, but it's not really a church. It's where I invite my patients and we pray and seek solutions to things when my back is against the wall and they are distressed and they have nowhere else to turn. Like, well, there is always an answer. You may not like the response, but there is always an answer, right? So don't get blindsided with that. These chromatin cells, they're difficult to locate, okay? And they secrete catecholamines, but pay attention to what they secrete. 20% of the time is norepinephrine, 80% of the time is epinephrine. And guess what? They secrete it directly into the bloodstream. It's like somebody giving you an IV push of epinephrine. Can you imagine how distressful that can be for you? So the patient, in order for us to, there's this rule of 10 that help us remember. They say 10% of it starts in childhood, 10% of the time they're bilateral, 10% of the time they're malignant, 10% they're extra-adrenal, most likely in the paragangliomas, okay, and 10% of the time they are not alone. They are along other multiple endocrine neoplastic disorders. Okay, you got that? How does it present? Look, headaches, palpitation, sweating, pallor, nausea, flushing, weight loss, tiredness, anxiety. Many of them present as if they are panic attacks. That's why everybody, before anybody that comes up to you with a history of panic attack, just make sure you exclude pheochromocytoma. because it presents just like hypertension. Okay? They get sustained hypertension, paroxysmal hypertension, orthostatic hypertension, and even hyperglycemia. Right? Now, many times people will tell you, oh, pheochromocytoma, you look for paroxysmal hypertension. Notice that is only true in 30% of the patients. 2/3 of the patients will have sustained hypertension. Okay? Very important that you remember that. So how do you evaluate pheochromocytoma? You do plasma epinephrine and norepinephrine. You order it. Okay? So anytime you're suspecting that somebody has pheochromocytoma, are these real coughs? Or you're telling me something? Okay, sorry. Okay, so you measure plasma epinephrine and norepinephrine, right? And together, you expect them to be more than 2,000 picogram per mil. That establishes a diagnosis. But unfortunately, sometimes it will be less than that, and the patient will still have pheochromocytoma. So when your combined level of epinephrine and norepinephrine is less than 2,000 but more than 1,000, you do what is called a clonidine suppression test. So you don't do, so if I ask you, how do you evaluate for pheochromocytoma, don't tell me clonidine suppression test. You have to do the plasma, epinephrine, and norepinephrine. If you have more than 2,000, you already have a diagnosis. If it's between 2,000 and 1,000, then you have to do clonidine suppression test, right? And non-suppression is what is diagnostic. If it is less than 1,000, just send the patient to a neurologist, okay? Because when it's less than 1,000, they do the glucagon stimulation test. And you're looking for a threefold increase in the plasma catecholamines, okay? Positive response. Don't get confused. Glucagon stimulation test is a stimulation test. You're looking for an increase. Clonidine suppression test, you're looking for a decrease. Okay? Yep.
So, is there a role for all those urinary DMAs and all that here?
The mandelic acid and all those terms, they are ancillary tests. But in terms of straight analysis and stuff like that, people come up with all those when they are in this range or in this range, and these tests are negative. Okay? We're doing away with all those VMAs and all those things, all those urinary tests now, because there are more sophisticated ways of measuring catecholamines in the blood. So we do mostly plasma. But that was not always the case. In the early days, we had to do urine vanillin, mandelic acid, VMA, and norepinephrine in the urine. But no, now you do plasma, and you do clonidine suppression test when it is between 2,000 and 1,000, or glucagon stimulation when it is less than 1,000. Got it? Okay. Now, this will tell you your patient has excess production of catecholamines. But where in the world is it coming from? That is when you have to do this test, right? You have to do radiological and radio-iodinated scans. So you have plain CT, MRI, you have PET with fluorodopamine, we call it F-dopa CT and MRI. You have this MIBG. All of these are radioisotopes, right? That are going to tag to your location in the patient. And this is an example of an MIBG scan. So when you do the MIBG scan, you see all the places that is pouring out the catecholamines to the system. Because yeah, you can establish that the patient has excess catecholamines. You cannot do anything about it until you know where the source is, right? So localization is extremely important. And these are the processes by which you do it. Everybody talks about MIBG scan as if it's the only way you can localize pheochromocytoma. But there is F-dopa scan that is equally effective. Okay? Now, how do you treat pheochromocytoma? Blood pressure control and surgical excision. Pheochromocytoma is one situation where if you miss it and you push somebody on a beta blocker, their blood pressure goes up instead of going down. Okay? So basically, how do you treat neurochromocytoma? You start with alpha blockade. You use calcium channel blockers. And you add beta blocker that are cardioselective. If you give them non-selective beta blockers, you will cause paradoxical increase in blood pressure. And you should know why that is the case, right? Because the beta-2 receptors are vasodilatory. They are the only receptors that are mitigating the effect of the catecholamines in the system. If you now go and block them, then you take out that protection and the patient's blood pressure will go up. Okay? You control that blood pressure and then you send them for the surgery and they take the surgery, just take the tumor out. Right? Bad news. Although surgical excision reduces the symptoms of malignant neurochromocytoma, the 5-year survival rate is still 50%. The location of the metastasis predicts patient survival, with bone metastasis being the best and lung and liver mets being the worst. Chemotherapy is associated with deadly catecholamine release from dead and dying chromatin cells, usually within 24 hours. Did you hear what I said? Even with your surgery, half of the patients will not survive. The half that survive, they have metastasis, and those metastases are in the liver and the lungs. You have to give them chemotherapy. But many of them will be dead in 24 hours with the chemotherapy, because when you kill the cells, the catecholamines they contain will be released, and you flood your patient out, literally, in that catecholamine surge. So this is not an easy disease to treat, and it's not rare. Okay, so just be aware of it and be on your toes. Look for it in everybody with hypertension. Look for it in everybody with panic attacks. And it's a very simple test you can order: plasma, catecholamines. That's all you need. Okay, so that's all about neurochromocytomas. Now the last thing is, there are times you want to do a CT scan for some reason. Maybe somebody has bowel obstruction, or somebody has an abdominal mass, a kidney enlargement, spleen enlargement. You're doing a CT scan for something else. And the radiologist tell you, oh, by the way, that patient you sent to me for CT of the lungs, I was able to see the adrenal, and there is a mass in the adrenal. Whenever you find a mass in the adrenal that you did not look for, it's called an adrenal incidentaloma. Okay? You have an obligation to figure out what is going on. Whenever you see an incidentaloma, the first thing you want to ask yourself is it active or inactive? So if it's in the adrenals, you look for it, is it active? You examine what could it be doing. It could be secreting cortisol, so you look for cortisol. If it is not secreting cortisol, then you're fine. Then, is it secreting catecholamines? Is it neurochromocytoma? Then look for catecholamines. So basically, this chart is basically telling you, what do you want to do if you have an incidentaloma? Ask yourself, is it active or inactive? And the way you find out is by measuring what you expect it to secrete. So that means you have to know what to look for. Right? That's it. That's all about it. You figure out what it is. If it's inactive and it's not bothering the patient and the size is not much, you send them to surgery, let them do a biopsy to make sure it's not malignant. If it is benign, you leave it alone. Sometimes what surgeons will do is to actually do excision biopsy. They take it out and then send it to pathology. If it's benign, everybody goes on happy. If it is malignant, you send them to oncologists to see is the excision curative or are they going to need the radiation or chemo. That's it. Okay? Good. All right. Can we do this? Are you guys happy now? Can we do some Some refreshing questions now. Right? Okay, so let's start with this one. We're going to do as a group. Right? So case one, what do you think is going on? Everything is low. Tertiary, good, good. Now you got it. Now what do you think is going on with the two? Eh? Okay, let's do that too. Secondary? Everybody agrees secondary? Yeah, because the high CRH exonerates adrenal, right? And the third one is what?
It's primary.
Primary. You understood this, right? Everything is low, it's tertiary. CRH is high, that exonerates hypothalamus, so it's secondary. Right? This and this and this are high, that means this adrenal problem. Right? You figured it out, right? Excellent. Which of the following laboratory results is not expected in a patient with the above reference disease? What don't you expect here in somebody with Addison's disease? High eosinophils, right? Good. In Addison's disease, high blood glucose? You don't expect high blood glucose? Oh, so sugar is supposed to be low, right?
Yeah.
You know what is interesting? When I'm straining, you all wake up in a very unique way, like solidarity. Okay, how about this one? This 52-year-old female has a history of persistent vulvovaginal candidiasis, presenting with dizziness associated with muscle cramps and weakness of specified duration. She couldn't tell you how long it's been going on. Physical examination is unremarkable except for sitting and standing blood pressure readings of this positively orthostatic, right? Initial lab results show low serum calcium, high serum potassium. Now the question, the presentation is most consistent with which of the following diagnoses? That is Whittaker, right? Yeah, polygonal autoimmune syndrome type 1. Because of the candidiasis, right? And the hypocalcemia. Got that? Everybody good? So, let me see how well you do with this. Because I know I skipped through Gordon's and matters, right? But I'm sure you'll figure it out from what we talked about, right? So, huh? What? Start with number 2?
Yeah.
I was even thinking we should start over here and then look for the answers over here. So let's start with, I'll go with you. So Addison's, what is it here? Okay, so that is D, right? Good. How about Cohn's syndrome? Cohn's is hyperaldo. Hypertension, hypokalemia. Good. Who said that? Excellent. So that is what that is. Cohn's syndrome, right? Hypertension, hypokalemia, and metabolic alkalosis. That is Cohn's syndrome. How about Cushing's? E, right? Hyperglycemia, right? Right? So now we've knocked off Cushing, Cohn's. Now we have to do with Gordon's and Batters, right? So which of these remaining two is like somebody taking loop diuretics? A, right? Exactly. And then what is Gordon's? B, right? Good, exactly. Okay. Just remember, salt wasting nephropathies. There are two basic types of them. Gordon's and Gittleman and Batters and Gittleman. Batters, because the defect is in the thick segment of the loop of Henle. So and that's the site of action for Lasix. So they present as if they are on Lasix, right? And Gittleman present as if they are on diuretics. All right. So this 48-year-old female with a history of diabetes and hypothyroidism presents with postural dizziness associated with intense muscle cramps and weakness. The patient reports taking folic acid and B12 injections for anemia, in addition to her metformin and levothyroxine. What picture am I painting here? Good. Physical examination is unremarkable except for orthostatic hypotension, patchy hair loss, vitiligo, right? Hyperpigmentation of the scalp, alopecia. Which of the following lab result is expected in this patient? So what do you expect? Low serum calcium. Exactly. Okay. Right? Because this Schmidt's is Addison's plus all this problem. You will not see high serum sodium in that, right? It's more like low serum sodium, right? You will not see high serum potassium. It's more like hyperkalemia in Addison's, right? You will not see low serum phosphate. No, you won't do that. And you will not see metabolic acidosis. It's more metabolic acidosis in Addison's. Right? So what you will not see is low serum. What you will see is serum calcium because of the associated hypoparathyroidism in Schmidt's. I think, well, we landed. Welcome to LA. Are you good? Any area of clarification? I recommend to you that it has come to my attention, talking with other instructors, that you guys don't have time to review what we're giving you. So it's like you're constantly learning new stuff. Unfortunately, that is true to some extent, but it's not altogether like you don't have time to review. That is not true. You cannot say you don't have time to review. You have to make time to review. It is the reason I'm breaking down your schedule and eliminating on useless activity to make sure that when you're in class for a week, at least you're getting new material for no more than 24, 30 hours. So that for the rest of the 10 hours that you're here, you have some time to flip through some things, prepare for some lectures, and your weekends, you're supposed to use those to review everything you studied the previous week. Extremely important that you do that. If you wait to midterm to review, it becomes distressing because midterms are like one day back to back, sometimes 2 exams in one day. You don't have time. You have to review as you go along. And make sure that in your review, put my classes first. Not because I'm important, but 40% of the questions in your pants are from my classes. If you flunk, I flunk. So make sure that you review something, neurology, cardiology, pulmonology, endocrine, every single week. Develop flashcards, carry them with you, put them above your toiletries in the bathroom. Read something when you're peeing, when you're pooping, read something. Recite something. When you're driving, read some things into your phone, listen to it when you're walking. I did all that because there isn't enough time in the day. You must double task all the time. Dictate some of your own notes into your phone and listen to it when you're driving. It makes a lot of difference. Believe you me, when I came here in 1991 and I was preparing for my step 1, step 2 of USMLE, there was so much to study at because I have to study everything from preclinical to clinical school. A lot. I decided not to buy a car because I wanted to sit on that route that bus number 21 that takes me from Wilshire and Catalina to UCLA because I was a patient escort. The drive is 45 minutes. That is 1.5 hours every single day, dedicated. And all I do is put those flashcards in my pocket. It was on the bus that I studied for 3 of those exams. Those little 30 minutes here and there, if you capture them and divert them effectively, they add up a lot. You know, so I want you to take advantage of every single moment you have. You must be learning when you're driving. Okay? You must carry flashcards. Put them in. There must be some things in your restroom. Because sometimes, you go to the restroom and you're like, wow, even though you went there to move your bowel, other things crop up in your mind and you'll be there thinking. And most of us, we spend about 15, If you're not in a hurry, 15, some people up to 30 minutes. Sometimes I have to go knock. Maybe are you okay? Because it's been in there so long, right? Take advantage of those times. It matters. It matters. Don't wait, please don't wait. It will not help you. It will not help you. You will not succeed if you wait to prepare for any exam. And moreover, you're not here to pass exams. Passing an exam is primary, but that's not why you're here. I'm not telling you everything I'm teaching you so you can pass your pants. You pass your pants, but that's not the goal. The goal is for you to be the best you can be. And the examination is just one of those things that prove that you're the best. The real deal is what can you carry with you? Your residual, how big is it? Look at me, I've been teaching now here for this program for 3 years, in medical school for at least 10 years. Do I remember everything? No. But what I need to practice, I carry with me. I look for a way to remember them. You have to do the same, because if you don't, you will not remember it. And you know the beautiful thing is that when you commit to retaining information, when you make the decision in your heart to retain information, your body will do what it has to do to help you retain it. That's why I don't support you memorizing anything. You don't need to memorize anything. All you have to do is read it over and over again and recite it. Remind yourself without whatever you're reading. I have little cards. As soon as I pick it up and I see the first sentence, I know everything in the card because I've read it so many times. I mean, in the church, nobody teaches you to memorize the Lord's Prayer, right? Just from repeating it every single day. For how many minutes? For like what? Maybe 5 minutes. Now you don't even need to be reminded. Once you open your mouth, our Lord, our Father, everything that follows. The same thing. Those little things you need to know about causes of things and how to evaluate them. Look for, develop what I used to call them flashcards. Little cards that you can carry with you depending on how much time you have. And some of them are already made. Look for good ones. A lot of what is out there is junk. The best thing is make your own. The things you consider, because many of you, if I give you one chapter to read, and I tell you regurgitate, many of you will regurgitate much of it, but with emphasis on different areas, because you're wired differently. Some are good with numbers, some are good with pictures, some are good with letters, and you will recall differently. You need to figure out what are you really good at, and those things, if you're good with numbers, then put down normal values of things and causes of high and low of them, because you're wired to retain that better. Some are good with pictures. Then figure out a way to build all your stories on what you need to remember around some pictures. That's some people do very well with study guides. Some are good with tables. Don't wait. All I can tell you is don't wait, because if you wait, you will get to your clinical year, which is just a few weeks down the road, and you look like you never learned anything. And then you have defeated the entire purpose of your clinical year. The expectation is that when you go into your clinical year, you're carrying with you at least a third to a half of information from your didactic year. So that when you're going to that rotation, you have come now to synthesize your emergency medicine, your internal medicine into one big beam. And in your mind, you know what is emergency and what is not. So when you're going for internal medicine rotation, you review those things that you know, these are not emergencies, but they're internal medicine stuff. You study those. And when you're going for emergency rotation, you take those things in, not only the things you learned in emergency medicine, but the things you learned in internal medicine that you know are emergencies. And there is no instructor in this program today gives you the kind of information I give you the way I give you. I make my slides very few on purpose, and I make them easy to give you information. Sometimes they look complicated and busy, but if you make the right note around them, once you take a look at that slide, the information should jump at you. Because many times, like this lecture, I didn't prepare for it. That was why I was a little bit fuzzy, if you noticed, at the beginning. Right? Because I didn't have time. It's the reason I didn't post your lectures. There's a lot of crazy stuff happening. I have to respond to them. But because I have done it, the picture reminded me, this is the third time I'm looking at this set of slides in 3 years. But why am I able to bring it up? Because number one, I have a good understanding of the concept. So those slides remind me themselves. It's not unique to me. It's not because I've been practicing medicine. No, many of what I told you today, I've not seen half of those cases. But reviewing it and taking advantage of every opportunity I have to review it will make it part of you. Because at the end of the day, your brain stores new information as a protein with a definite half-life. So if you study it now, you remember it. But if you don't study it again in a reasonable period of time, that protein will disintegrate and you'll forget it. But if you keep studying it, even if it's every month, your body will keep synthesizing that information as a new protein with longer half-lives. Until finally your body realizes that you need this. And then the half-life is indefinite. That is the way the body works. You have to have a periodicity in your review and revision. Yes, Lord.
I appreciate the fact that you give us very few slides, but there's some classes that give us too many slides that takes so long to review. For instance, pediatric on Friday went over 200 slides.
It's unfortunate. It's unfortunate. Believe me, I'm aware of those classes. I'm working with those instructors. It's a slippery slope, right? Because as you all know, our faculty complement is kind of low right now. So you don't want to piss people off too much, you know. But once you're ready, you come on strong. You say, I need you to fix this. Like Anita Nelson, you need to talk to those that took our class last year. My students were crying because she was stressing people out with a lot of useless information, research stuff. And I had to say, and I couldn't do much because, she doesn't get paid, right? And she's so, all she gets is some tax write-off for whatever she's doing. So we are careful the way we relate to her. You don't want to piss her off, and she's very good. She's very, very good. So you have to help manage, work with her. So the slides are less, but they are still a little much. But we are making it. So what I want, bottom line that I'm trying to explain to you is, after every class, you should know by now what is junk, what is extra, and what is neat. After every class, take the 200 slides, cut out the crap, create your own dense slide for your own review. Because I review the questions. And believe you me, I always eliminate questions that I believe are unfair, unnecessary, or not relevant. It is the reason your OBGYN result came out the way it did. Because I invalidated many questions because they're not fellows, they're primary care providers. If anything is important, it's the guidelines. Teach them what they need to know. At least you can put 10% of the questions to reward the overachievers because some of you are overachievers. But at least people shouldn't flunk because they don't know extra stuff. They should flunk because they don't know basic stuff. So we're getting there. I just need you also to do your part. Don't wait. Don't wait. It will hurt you. Don't wait. If you wait many, many times, it will be too late to cry when your head is cut off.